What we want to do is cover some of the things that kind of where we are now in terms of treatment, and then go into some possible future options that aren't quite ready for prime time just yet, but might be hopefully soon on the horizon that would really revolutionize some of the therapies that we're looking at. And so so in terms of where we are now, I think the first part to keep in mind is that when we talk about epilepsy in children, that pediatrics really is one of the most common times in life to see epilepsy. So there's sort of a dual peak for epilepsy, but it's extremely common in young ages, especially under age 2, and then it actually grows in frequency as you get more elderly, like after 70s or so, and that's because stroke is a very common cause for adults. So pediatrics really is one of the most prevalent times to see seizures and epilepsy, and the causes, when we talk about seizures and epilepsy, we're really talking about many, many possible causes of seizures, and that's especially true in pediatrics, more so than adults. Most adults with epilepsy will have had stroke or some kind of brain injury that led to it, because as we grow older, we kind of accumulate more possibility of having had a brain injury. But in children, we're really dealing with quite a mixed variety of different possible causes. So the main split I kind of think of sometimes would be is that there are some people who have had brain injury as a cause, and then there's others who might have more of a genetic basis. The genetics are pretty new. We're just beginning to really understand how a lot of that works, because some of those tests that we use for genetics are really have only existed in the range of some of the tests we use are only like a couple of months old. We've gotten to a point, for example, there's very recently in the last couple of months, there's been a new genetic study approved that will cover over 60 genes in just one blood test. And all those genes are known to be important for possible causes of epilepsy. And with one blood test, you'll actually sequence over 60 genes at once, which is a pretty incredible thing. We had nothing like that in the past. It looks like we're running. There was never anything remotely similar to that, up until the last year or so. So we're really just now at a point where we're beginning to understand that, and that will hopefully begin to translate to what some of the future therapies are. So even when it comes to causes that involve brain injury, there's still a lot of potential for future understanding that would lead to future therapies. So the process of brain injury is something that, from a scientific level, there's a lot of area to understand exactly how that can ultimately translate to seizures down the road. And so for both of the main two causes of epilepsy in children, both whether it's brain injury or whether it's more of a genetic or metabolic cause, in both situations there's a lot of opportunity to hopefully find therapeutic options that would really improve the condition. So let's see if we'll get this.
Just play?
Yeah, here, let me see. Let me pop on. Actually, why the screen is... Let the screen change. All right, so give me 1 sec. I'll get this running. I had to be complicated and use a Mac. And the screen size changed on me. Let me get that to work out. Give me 1 second. What I'll do, I'll just play it. Okay. All right. So this way I can use my iPhone. So this is like the great thing about the Mac. This just shows the what I was talking about in terms of age of incidence of epilepsy. That there's really 2 peaks, very common in children, very common in elderly. So, but right now, I think the thing to, I guess the thing to know that many families unfortunately already know is that we're very limited in terms of a lot of the therapies presently. We're either limited because they're not working well, or we're limited because of side effects. But it's not uncommon that a lot of patients, a lot of kids have to deal with one or both of those issues, that it's either just not working well or that they're really burdened by a lot of side effects. On average, about 50% of kids will actually have a very good response to the first treatment, will tolerate it, and will have seizure freedom. But when we look at the rate of people who are not responding to medication, it's a little more than a third of patients who don't respond even to multiple medications, even when used together at the same time. So there's obviously a lot of need for ongoing research and development in terms of better treatment options. But why we treat seizures? I mean, I think there's no requirement that we treat all seizures. So there are some kids who have really subtle seizures that don't present so much of a medical risk, and so there are some situations where we actually don't treat. I'm getting paged already. Let's see. I'll get back to them later. An example would be benign Rolandic epilepsy, which is the most common form of epilepsy in childhood. Many times kids will have, their seizure will consist of just like numbness around the lip, or sometimes a sensation of the hand, or sometimes jerking of the mouth or face. And those usually happen in sleep, but they're not necessarily dangerous to the child. And we know that those kids will outgrow that seizure type. That's a seizure type that you outgrow pretty much 100% of the time. So the consensus is not necessarily to treat that type of seizure, as long as it's not more significant or doesn't present a safety concern. But we do worry about, particularly for what we call a generalized tonic-clonic or grand mal seizure, or any kind of seizure that would affect respiratory patterns. Sometimes complex partial seizures where a child's staring and unresponsive, we can see their respiratory pattern affected. Obviously, we want to reduce any potential risk of injury. And the primary thing we worry about are really the lungs, because sometimes the respiratory pattern is just a little more shallow or slower than it should be. And kids can also be at risk of aspiration sometimes. They can't always protect their airway well. And that's one important reason to treat. We also have to think about possible risk of falling or injury that way. And that really depends a lot on the age of the child, how active they are. Very young kids are going to be monitored by adults 24/7 anyhow, but as you get into the teenage years, that changes. And so we have a whole different set of issues. So for example, a child who has absence seizures when they're 5 years old is very different than an 18-year-old who's driving in terms of the consideration. I don't necessarily feel like I have to stop every single absence seizure in a 5-year-old because they're not driving. If they're infrequent, they may not cause any harm to the child. But for an 18-year-old, it might have a whole different criteria. I might really have to try to achieve seizure freedom. So those kinds of things really change with age. And we have to think about, what's the effect in terms of school and academics? What's the effect in terms of overall quality of life? Things like self-esteem become very important. I've had kids who have had infrequent absence seizures, but when they happen, they sometimes have had urinary incontinence. And so, if you're middle school is hard enough as it was for most of us. But imagine, having to experience incontinence in the middle class. That would, just be devastating for a lot of kids. So there's certain situations where even though maybe the number of seizures wasn't so bad, the fact that it was really affecting self-esteem or caused that kind of an embarrassment is really an important consideration. So a lot of different reasons why we think about using treatment. Whoops, sorry, I jumped ahead. Usually, though, when we decide though to treat, it's usually because we're really not thinking about so much the past. We have to kind of like project to the future and try to make some determination of what the risk is of ongoing seizures. And when we do that, a lot of the epidemiology that we use to make that decision is based on all kids with all seizure types. So it's very hard to say this for every individual patient, exactly what it will be. But on average, if you have a child who's had a first unprovoked seizure, you're about 50-50 on average. Your risk of a second seizure is better if your MRI and your EEG are normal and the examination is normal. If those things are abnormal, it's a little higher. But in general, after a first seizure, it's about 50-50. After that second seizure, though, it really jumps up quite a bit. So when you have a second seizure, the risk of a third is somewhere around 80%. So it really changes the discussion of when to use treatment. We obviously don't want to start everybody who's had a first seizure on medication because we would be over-treating a lot of people. So if 50% or a little more would not have a second seizure and we started medicine, then we're basically treating a lot of kids who don't need medicine. But after that second seizure, that's often why people sometimes wait until then to consider treatment. Is that the risk really does change quite a bit. And so again, in making that determination, we do use other data sources. That we look at the past history, look at the exam findings, EEG data, MRI data, to try to kind of get a little bit of a better sense for that individual patient, what that risk of recurrence will be. And when we do treat, when we make that decision to treat, really the primary goal is hopefully to achieve both seizure freedom as well as side effect freedom. And so obviously the top thoughts that we have when treatment would be both what's the safety of the medicine and how effective is it. And so you want to obviously find something that's both safe and effective. Many times if you're starting a medicine, it's the first medicine, we're going to err a little on the side of trying to pick what we think is the safest. Like I might have a few that I think are very effective, but if they're not, if they have serious risks like liver toxicity or causing severe anemia, that's not going to be my first choice. I probably would start with this, what I think is a safer one, and then only reserve the ones with higher side effects for if there really presents more of a problem. But you have to think of each individual kid too, because when it comes to kids, there are different considerations. Like, will this child actually take the medication? That's like one of the very most basic things. But I can't give a 5-year-old a huge horse pill that has to be swallowed whole. That's not going to work. We have to think of the taste. A lot of kids have sensory integration issues. It's not so easy to hide a medication. So there are a lot of different factors, and not all the medications are flavored in a way that's very palatable. I haven't personally tasted all these medications. I don't think that's a good idea. But so I can't vouch for exactly what the experience is with each kid. But everybody has different tastes. So some of the kids will say they love this one, other kids will say they hated it, and it's the same medicine. So, but some of them are flavored fairly strongly. So depending on the child's preference, they may or may not like that. But those are important things. So I've had a lot of situations where the child's spitting out the medicine, and that's obviously not going to work either. So we have to think of, we do have to consider each individual child and, think about what's going to work best for that individual patient. Unfortunately, cost comes into this a little more than we'd like, because insurance companies now get very uptight about, particularly some of the newer medications, how they're going to improve that or if they're going to improve that. One thing to think about that we never used to have to think about is when someone is in the hospital, if they start a new medicine and then they're leaving, there's a high chance these days that the insurance company would not approve it. And so you go home, you think the medicine's going to be all set, and it turns out it's not. And then they tell you the cost is like $800. And what are you talking about, $800? But what happens is they need like a pre-approval, and to do that you have to send these forms. They have to spend a lot of time filling out forms and explaining why this medicine has to be chosen, and then you wait for some guy to approve it. It's like a mess. But 10 years ago, we didn't really have that problem. You just sort of wrote the prescription and it was all set. Today, you actually have to think that ahead. And part of this issue, the new, is that there are a lot of new medication choices, and that's why this kind of issue comes up. So, the list on the right is pretty small because there's been a lot of new additions over the last 20 years. But traditionally we think of certain medicines as kind of older ones, certain ones as newer. What's really interesting is phenobarbital's 100 years of experience there. So that's amazing. We've been using this thing for 100 years now. Generations have grown up on it, and we still use it. It still remains one of the first choices in newborns, despite the fact that it's 100 years old. Part of the reason we tend to reserve it for newborns is one of the concerns in a newborn is you want to have some confidence about what happens 50 years from now when you've started medicine. You kind of want to know that there's not some weird long-term side effect. And so at least with this one, because of all that experience, there's a little more of a comfort level. But so it's sort of like the devil you know versus the devil you don't. And sometimes when it comes to a newborn, you're a little more likely to stick with what's tried and true. A lot of the other ones we still use as first line, for example, ethosuximide, or Zerontin is the brand name, we've been using since 1960. That still is first line for absent seizures in kids. So even with all these new medications, that really remains the first choice. Carbamazepine is still a very reasonable first choice for partial seizures in children, and we have a lot of data in children for carbamazepine, so it's not a bad consideration. So with a lot of these new ones, though, I think even though we have so many new ones, what's important to know is that that rate of responders has not really changed that much. You think in the last 20 years having 10 or more new medications, you would think that we would have that we really would have shrunk down the percentages of people who don't respond to medication. Unfortunately, that hasn't really been the case. So with all these new medications, we just haven't made as much a dent there. The place where we made a little more of an improvement is actually with side effects, because not that the side effects are necessarily better or worse with an older or newer one, but they're different. So we have more options in terms of what the different side effects can be. In general, a lot of the newer medications tend to have a little bit less in the way of like liver toxicity or bone marrow toxicity, which is nice. So usually for some of these, we don't have to do blood draws, which is really critical in kids. 10 years ago, 15 years ago, a lot of times kids were on Dilantin, Depakote, Tegretol. Those were common choices, all of which require blood draws. And so, kids would go every 3 months or every 6 months and get their blood drawn, and it was never a fun experience. But again, we have a lot of options now that don't require that, which is nice. The downside, though, is that a lot of newer medications do tend to be expensive. So anything still that's brand name only is going to be, they're going to charge you for that if there's no generic available. Even the generics can be pretty expensive. One thing to know, though, that when it comes to generic versus brand name, is they really are the same compound. So we're not dealing with a difference there. But the main thing is that there are, for each generic, there's not like one generic. There's actually, most of these makers actually have about 10 different companies making, like for example for lamotrigine, there's probably about 10 or 15 companies that make lamotrigine. So if a pharmacy changes you from one generic to another, it may not be exactly the same concentration. So the FDA allows you to be somewhere between 80 to 120% of what the brand name is. So the actual amount, the actual content can vary quite a bit. It could be 20% plus or minus of the brand name. So for some people, 20% doesn't matter. And it probably doesn't matter at all if you're dealing with like a cholesterol medication. That's probably not as critical. But when it comes to a seizure medicine, a 20% difference could be the difference from side effects versus no side effects, or seizures versus no seizures. So anytime there's a switch from one brand to another, and the pharmacy won't necessarily tell you, if you're on one generic and then they change their contract and then you go to pick up your pill and it used to be orange, now it's purple. That happens, and that can be a different concentration. It doesn't mean it won't work, but it's something that always important to ask. If it doesn't look the same, just ask what's up. One thing to note too is that with a lot of the newer medications, a lot of them don't have as much in the way of literature specific to kids. We do have some. I kind of note here that we have a lot of the newer medications do have FDA approvals, but each one has sort of a different age that we've studied and slightly different indications. So it really depends on how the studies were structured. But for a lot of the newer medications, the age is very specific. Like levetiracetam, it's FDA approved for ages 4 and over. Now we use it quite a bit in kids under 4, but the FDA approval can only occur based on what the study studied. So they can't approve it for something that wasn't studied. So that's kind of how it works. Now some of them are only approved for adults, and that's always an important thing to discuss, I think, whenever we make a decision to use a medication that's not been studied in kids. One reason we do that is often in that situation we've typically tried other medications, and so this usually is not the first line medication when we're using an adult-only approved treatment. But usually what's happening in that decision is that there is some reason, either because of efficacy concern or side effect concern, that we still may feel that this could be the best choice, but the data in kids is either non-existent or very limited. And so there are examples where we do that. Like for example, there's some medications that have very specific mechanism of action that we might think it would be the best for that particular child. Like for example, there's only one potassium channel blocker that exists in the market, and whoops, hold on, sorry. So it's one at the bottom. Ezogabine is a potassium channel blocker. That's the only one, or not a blocker. I'm sorry. It actually improves the function of potassium channel, but that's the only one that acts on that particular mechanism. So for some reason, if I really thought that child, that's their mechanism, I might choose that, even though it's only approved in adults. That's the kind of situation where that might come up. But it's not usually a first-line kind of treatment when we do that. So, in terms of how we choose medicine, a lot of it, I kind of list this you don't have to, I guess, know each of these individual medications and what we choose them for, but basically this is how a neurologist would think, is we have to think of what seizure type the person has and then kind of base it on that. So partial seizures, meaning that they're arising from one part of the brain. Usually we think about things like oxcarbazepine, which is also under the brand name trileptal, or carbamazepine, which is Tegretol, as a first line. And these are, you need your reading glasses for this, but for generalized seizures, it depends on what type. Is it like a generalized tonic-clonic, or what we call a grand mal seizure? Is it myoclonic, which is like a really rapid jerk type movement? Is it absence, which is a steering spell? So each one would have a different sort of first-line therapy or second-line therapy. And so, we think of really the seizure type as being very important. And then there are certain syndromes where we have very, very specific treatments that we would use. Infantile spasms, for example, or Lennox-Gastaut syndrome, have had specific treatments that seem to be most effective for that specific syndrome. Other things like juvenile myoclonic epilepsy is very common in adolescence and adulthood. And again, we have studies that really look at what are the best therapies for that specific syndrome. So if a child has a very specific, something more specific than just saying it's partial or generalized, that's important because we do have some studies that will help define what's the best treatment approach for that child. Where we want to get into, before I get to the discontinue though, where we want to get in the future is actually to get a little more specific than that though. So it's great to be able to say this is a partial seizure, so this should be the best medicine, or this is generalized, so this should be the best. But we might hopefully get to a point where we can really get more specific than that. I think so where I was going with the idea with the genetics is that maybe, now that we can screen so many genes, and this kind of testing may hopefully get cheaper and cheaper, so it's more easily utilized, we might get to a point where we can actually say to a child that you have a specific sodium channel cause of your seizures, and therefore these are the medicines we should use and these are the ones we shouldn't use. And so right now we don't have that kind of level of data for each child, but that's not too far off. One of the hurdles though with genetic testing is cost still, because this kind of screening is in the range of, for example, this 60 gene panel is about $7,000. It's not cheap. Insurance only covers its portion of that, so depending on the size of the copay, it could still be a pretty significant cost to each patient, each family. But those, just like computers had gotten faster and better and cheaper, we're seeing the same thing in genetics. And actually the problem won't, 5-10 years from now, I think we're going to get to a point where we can do a whole genome for under $1,000. I mean, it's really taken off in that kind of rate. So the problem actually won't be whether we can do the study, the problem will be whether we can interpret the data. Because the more and more genes you start to evaluate, the more stuff you find, and then the question is, it's not a question of whether you found any finding, it's a question of how do you figure out what to do with these 100 findings that you found, and which one's actually important. That becomes more of the challenge. So that will get interesting, because we will have, I think if you think of, kids growing up now, like a 2-year-old today, when they start thinking about family planning or when they have kids, we might actually have available doing a whole genome for a very minimal cost. It might be a couple $100 or something to do a whole genome, which when it was originally done by the NIH was hundreds of millions. But again, the challenge will be, do I really want to know that I have that cancer gene or not? Is that a really good idea to find that out? And what do I do if I get that result, and how do I process that, and how do I make sense of that? And when it comes to genes involving the brain, there's so many genes for the brain, so how do I make sense of the fact that they're going to be, inevitably with any of us, when you do genetic testing, you're going to get 100 different changes. And how do I interpret that? That really becomes difficult. We'll get there, but for now, oops, I skipped that one. But for now, that's something that we're really in the infancy of. So, and then just to get to, what we hope to achieve with treatment, though, is that we hope to get to a point where a child's been seizure-free long enough that we can actually consider coming off the medication. An important thing to know, though, before starting a medicine is that the medicine itself, none of these medications actually help a child, help the seizures become outgrown. So these are not like antibiotics. You're not, just like when you get penicillin or whatever for your infection, the infection goes away, it's cured. That's not how these medicines work. They're more like a Band-Aid. You know, when you put a Band-Aid over a wound, it's the skin that has to heal the wound. Not the medicine doesn't heal it, it just keeps it covered. So just like a Band-Aid, the only way you know if that wound is healed is you have to kind of peel the Band-Aid back and take a look. And that's really what we consider with medication. So, you know, in terms of the timeline, the reason we think about 2 years is that as many as 75% of kids, after 2 years of seizure freedom on a medicine, as many as 75% of kids will have outgrown it in that time frame. So 2 years is a common time frame that a lot of neurologists will choose. If you look at 1 year, the data is about 50-50. So you could, there's no firm rule that it has to be 2 years, but you know, in general, by giving yourself a little extra time, you've increased your confidence a bit. And then you have to look at a lot of factors. Like, if a child's just getting ready to start middle school, that's probably not the best time to, you know, you don't want to pull away medicine right in September. You know, usually I wait until they've adjusted to school, make sure that there's not some big change. If you're going on a family vacation to Timbuktu or somewhere where there's like limited medical care, maybe we don't want to start messing with the medications right before leaving. So, you know, it's a lot of factors. It doesn't even have to be such a big trip. I mean, even a trip to Florida or something, you know, may not be the best time to pull the medicine right before you get on the airplane. So we, you know, so we have to think of all those factors. So this is not like set in stone that it has to be exactly 2 years. So and then we do think of some other things like what the cause of the seizures has been is important in terms of recurrence. So for example, some seizure types are definitely outgrown, like Rolandic epilepsy, 100% of those kids are going to outgrow it. So at some point we are going to come off medicine. Other types can actually continue into adulthood, like juvenile myoclonic epilepsy. So we're less likely to taper. And if they're going to recur, if you're going to see seizures at the 1 year mark, you're somewhere around, on average, about 70-75% will have shown up in a year. When you go out to 2 years, you're well above 90%. 90-95% will have shown up within 2. So, but that depends too on the seizure type. Like if you had a child who was having 30 seizures a day before the medicine, and then you taper the medicine, you don't have to wait 2 years to see a seizure because they're having so many. Whereas if you had a child who had 1 seizure every 6 months, and you do a taper, you probably have to wait at least a year to start to feel really confident. So there's a lot of individual factors with that. And this just kind of shows what I was talking about in terms of responders and non-responders, but this is just kind of a graphic showing that when you start a first medicine, you're about 50-50 on the first one in terms of who's responding, who's completely seizure-free. But of the non-responders, so of the people who didn't respond here, when you start that second, you're going to get another 13% or so who are seizure-free, but still that leaves about 40% who are not. As you start a third, you're actually getting even less benefit from that third. And then as you start adjunctive therapies, adding 2 medicines at once, or 3 medicines at once, you're still only picking up a small percentage. Part of the reason for that is we have not yet found all the mechanisms of seizures. Not all of our current treatments are addressing every possible mechanism. Some of the therapies, even the newer ones that we have, actually may work on the same mechanism that a lot of the older ones worked on, so they're really not that different in terms of how they work. So, but clearly that shows that we need ongoing research, and we need to think about perhaps changing the whole paradigm of how we approach seizures and start thinking outside the box. And actually you know what I'll do? I'm going to jump ahead to segue into that. I'm going to just jump over the surgery part. Give me 1 second. This is all nice pictures and stuff, but I want to just jump to a different part because I want to get into some of the horizon things. Because this, I think the real question is if the petals on the flower are the seizures, I mean, the real question is what's underneath that. The roots are bigger than what you see on the surface, sort of like the iceberg analogy. But the root causes are the key. You really want to get at those root causes, and that would really give us the best. That would probably give us the best efficacy in terms of therapy. Most of the seizure medicines we use now don't address the root causes, so that's why I say they don't help you outgrow the seizures. They're simply stabilizing the neuron to prevent it from firing, but they're not really addressing what led to the seizure in the first place. So the, for example, like a sodium channel medication or calcium channel medication, they're really designed just to stabilize that nerve cell so it's not firing inappropriately. The cause itself may be very different from what we're using it for. So the question is, can we get at some of these root causes? And if so, maybe we can think of treatments that fundamentally improve the neurological condition, not just the seizures. And I'm just going to give you a few examples of where this might head in the next maybe 10 years or so, but you know, this gets speculative, so we're not going to jump out to any of these medications or any of these approaches yet, but this is where we might start to see some changes. I'll give you a few examples. So one big category would be neurotransmitters and how we think of those. And so an example there is glutamate is going to be an important neurotransmitter because this is the excitatory neurotransmitter of the brain. And we don't really have a lot of treatments that act directly on glutamate presently. Topiramate does to some degree, and felbamate does to some degree, but most of our treatments don't act on this mechanism. But glutamate may be very important for both migraine and epilepsy because it is, again, it's an excitatory neurotransmitter. And an example of where this might be important is the condition Fragile X. So actually a lot of the research understanding Fragile X took place here in Providence. And so we have now a much better scientific understanding of how this disorder works. And not to get, I don't want to burden you with too many of the details, but I'll give you a sense of what the overall picture is in Fragile X, because it's more than just epilepsy. And this is common, really, when we deal with neurology, this is the way things really work, is the brain, it's one brain. So many times kids will not have a single issue from whatever the cause is. It could be more than one thing. And so for Fragile X, it's very common to see intellectual disabilities, sometimes problems with attention or hyperactivity. Anxiety is very common, or mood difficulty is very common. And many kids can have autism as well. So this is really a mixed thing. Sometimes sensory integration problems, things like speech delay, and then, of course, epilepsy, too. And that's about a quarter of patients with this condition will have epilepsy. And so what we know about it, and we've kind of understood a lot more about this in the last 10 years, is we now understand the gene. It's this FMR1 gene. But basically, what it does is this particular protein that the gene makes helps to reduce protein synthesis. So the gene itself is kind of keeping protein synthesis in check to some degree. And when it's not working, that protein synthesis goes a little haywire and just doesn't stop. And in particular, one of the things that protein synthesis has to reduce is a glutamate receptor. So glutamate, again, is the excitatory neurotransmitter. So if this gene doesn't work, you actually produce way more of a particular type of glutamate receptor than we need. And when you have all that extra glutamate receptors on the cells, it means that the cells are activating. They're much more excitable because glutamate's the excitatory neurotransmitter. So with too much of those receptors, the cell's just kind of firing all the time. And that's why you get things like seizures and such. This is just a schematic. You have to have this whole thing memorized. But just the schematic of, just to show you how complex the pathway is. So this is not meant to demonstrate what we necessarily need, but just to show how complex this gets. But the glutamate receptor, like if this were the cell membrane, the glutamate receptor would sit here, and then it'll affect a whole cascade of events. So it's not an isolated thing. It really has many, many effects on the cell. And in particular, this is what we call a metabotropic glutamate receptor, but there's two main classes of them, but it's something called mGLUR5 is what is most important for Fragile X. And that particular receptor, this receptor is the thing that gets overproduced. And so when you produce a lot of this, it means that all this cascade is being revved up all the time. And some of that leads to that hyperexcitability of the nerve cell. It just fires too easily. And just another schematic, but one of the ideas is that if normally this protein in Fragile X normally keeps protein synthesis in check, so this glutamate receptor, you only produce a little bit of it. When the Fragile X is, when that gene is affected, then you produce too much of that glutamate receptor. But one idea is to try to look at medications that would block the receptor so it's not firing. So that rather than, we can't necessarily put the gene back, but you could probably try to find things that will act directly on the receptor so that the protein production still remains the same. And there's actually, now that we know how Fragile X works, now that we know it relates to this very specific mGLUR5 receptor, glutamate receptor, right away, a lot of pharmaceuticals jumped on this and are currently studying, 4 different compounds. Now, the question with these, which would be interesting, is, as I showed you, Fragile X causes a lot of things. So it can cause anxiety, can cause things like autism, attention deficit, sometimes pain, epilepsy. The question is, which of those things will these compounds work the most with? We don't really know that right now. But I could say there's a good chance that 1 or 2 of these will probably show something, as far as epilepsy, that we may see some benefit. And one of the things that would be interesting is maybe, Fragile X itself is not that common, but this is such a new approach to how to manage epilepsy that even though this is more specific to Fragile X, it may actually apply outside of that one condition. That would be one of the thoughts. So that's what we kind of learned from basic science. And another pathway where we think of the same thing has to do with growth regulation. So again, kind of going through big categories. So neurotransmitters was like one approach. Another thing that's important is how the brain and body regulates growth. And one of the ways it does it, another complicated molecule is this mTOR, which is a molecule that is very important for growth regulation. As you can see, at the cell, it has a whole cascade of effects. One of the reasons this is felt to be important for epilepsy, though, is that when it comes to the development of epilepsy, is that there are a lot of processes that will direct cells to kind of branch out. The dendrites will kind of branch, make connections, and so that kind of growth regulation is very important for when and why epilepsy may develop. So, for example, after head injury or trauma, there's a cascade of events that'll happen where the neurons will start to heal and recover. Part of that involves growth of dendritic branching and axonal sprouting, and what's regulating it is this kind of compound. And so those, if we can do something that will kind of hold that process leading to epilepsy, that would sort of be the hope. So the other thing too that gives us some indication that this might be important for epilepsy is that we know that this particular growth regulator is affected in conditions that are associated with epilepsy. Tuberous sclerosis, for example, or neurofibromatosis. These are disorders where mTOR, where this growth regulator gene, is affected, and epilepsy is very common in these conditions. The last one, I want you all to say 3 times fast. Aniyan Riley Rubel Haba. Anyway, so when three doctors are working together on a disorder, you gotta just make it like Smith and something easy. Just like these guys should have never gotten together. Anyway, but this just gives you a sense that mTOR is actually important in some sense for genetic conditions, but also for things that have led to brain injury. So a lot of things will act on it. Like, for example, there can be genetic causes that are important for this growth regulator, but things like status epilepticus, which is prolonged seizure, might also activate this growth, or traumatic brain injury. And then ultimately what happens is that growth regulator protein will start to affect the ion channels and the neurotransmitters. It'll affect the axonal sprouting. All these things, the cell growth and proliferation, all these things that may ultimately lead to the development of epilepsy. And so the idea is that if we use something that blocks it, that may not just improve epilepsy, but maybe it even prevents it. And so one of the ideas is to use rapamycin, which is known to block this growth pathway. And when you give it to, there are mice that are a model for tuberous sclerosis, and these mice who have the tuberous sclerosis gene will definitely develop epilepsy. But if you give them rapamycin, if you give mice that have already had epilepsy rapamycin, what you'll see is, actually if you give it to them before they develop epilepsy, they won't even develop it at all. It'll delay the onset. If you give it to them, so if you give it early, it's totally prevented. If you give it a little bit later, you'll still reduce the seizure frequency. You may not stop it completely, but you'll at least reduce it. But the thing to know is that once you stop it, the seizures would redevelop. So the mice, the mice who had gotten it before they ever developed epilepsy, if you can keep them, you can prevent it, but then once you stop this treatment, eventually they kind of go on to develop it. So it'd be something that'd be a little more long-term. But the thing that's really exciting about this is that, for example, in tuberous sclerosis, one of the other things that are common are issues of like autism is very common in tuberous sclerosis. Attention deficit is very common. So it's not just epilepsy, there's also a learning component. And what's really exciting about this particular study in animals, at least, is that we also saw an improvement in the learning deficits from tuberous sclerosis. So it wasn't just the epilepsy. And this is striking because when you think of all the current seizure medications, none of them seem to come to mind when it comes to improving learning. In fact, it's like the opposite is really the concern. Is how am I negatively affecting learning and education? So this gives you some hope that maybe we can actually, if we could fix the neurological problem at the root level, maybe we could actually improve development and improve epilepsy, is sort of the idea. So, and unlike seizure medicines, this treatment doesn't do anything for reducing the excitability of the neuron. It really just affects more of the growth pathways. And so it would work more on the kind of gradual, slower processes that are involved with with the development of seizures. One interesting thing, though, is the keto diet, which we're going to talk about, may actually act on a similar growth pathway. It might have similar effects on this mTOR pathway. So that might be one of the mechanisms by how it works. We're very limited in looking at this experience in people, but actually this medicine, rapamycin, has been used for certain types of renal cancer, and so some of the data from the experience with that type of renal tumor was looked at, and of kids who've had epilepsy, for example, there was a 10-year-old girl who'd taken rapamycin for her renal cancer, and she also had epilepsy, and it was noted in this case report that her seizures stopped when she was on the therapy, so that's encouraging. And we still need many more trials, but there was also another study that tried to pull out 16 kids who had seizures who also got this for renal tumors, and of those 9 had an improvement, and the rest seemed unchanged. So we don't really, it's so limited. We're talking about just 16, a small handful of kids who've ever tried it. But we do have, right now, there are clinical trials for tuberous sclerosis, at least there are ongoing clinical trials looking at this kind of therapy. One is going on in Cincinnati Children's. Dennis Franz is the person who runs the tuberous sclerosis clinic there, and he's probably the expert right now in the world of approaching this type of therapy. But we need more of that to try to see where this will lead. And I'm gonna move through the next few quickly because we're getting towards the end. But another big picture, though, so I mentioned, again, we talked about neurotransmitters, talked about growth regulators. Another thing that's important to seizures and epilepsy are how these different channels that are on the neurons respond to the inputs that tell the nerves whether to fire or not to fire. Our nerve cells have many different channels. We have sodium channels, we have potassium channels, calcium channels, and they're there to basically tell the nerve whether to fire or not. And one of the things that's become really, has really improved our understanding of seizures has been the recognition that this very specific syndrome, Dravet syndrome, is related to a very specific type of sodium channel. And in Dravet syndrome, again, just like all the other things that we mentioned, it's not just about the seizures, but it's very common that a lot of kids will have had concerns with development or with learning. Speech delay is very, very common. Many of the kids in Dravet syndrome actually had a bad reaction to vaccination too, and many of them had experienced a first seizure with vaccination. So that's very specific to this. But now that we know that this is a very specific sodium channel, we can, now that we have that understanding, we know to avoid certain medications that block sodium channels. And we are beginning to try to understand how, if we can prevent prolonged seizures in these kids, how that might actually improve their long-term outcome as well. And we might start to look at more specific therapies too that would act on that particular channel, like verapamil, for example, which is it's a calcium channel blocker, but it might have some benefit there. And we use it typically for blood pressure. It's not typical epilepsy medicine, but it might actually be relevant. And then this would just be the last, so I can let everybody else have time to speak. This would just be the last example where things might really change is the understanding of immunologic causes of epilepsy. And this is not, we don't typically think of the immune system and epilepsy together, but one specific example, though, where the immune system may actually be the cause is in this condition of what we call NMDA receptor antibodies. Again, this gets back to the glutamate idea, but NMDA is a type of glutamate receptor. And what happens here is that people may have antibodies that actually attach to that receptor, causing the nerve cell to fire. And so it's like an autoimmune condition, essentially. And instead of the immune system attacking, unlike lupus where you might have it attack the kidneys or something, here the immune system is actually attacking the brain in a way that's causing neurons to fire when they should not. And so what you can see, a lot of things, you can develop seizures, personality change, irritability, depression. There was even a case of autism that was associated with these particular antibodies, but all kinds of things, memory problems. Usually in these patients, though, it's not like just one of these. So like memory problems alone, we wouldn't necessarily work this up. It's usually much bigger. It's really like a true regression of development. Really bizarre behavioral stuff, like hallucinating, just really very delirious, and then plus the seizures. And that would usually be what would lead us in this direction. And there are specific findings that we can look at that are common here, but the main thing is that we can actually, in about 60% of patients, will be positive for the blood work titers for this particular antibody. And the way we would treat that, that would be the last slide, but the way we would treat that would be with immunologic therapies, not with traditional seizure medicines, but things like intravenous immunoglobulin or steroids or other anti-inflammatories. Now we do have some examples where we use immunologic therapies for epilepsy, and so for example steroids and ACTH are used for infantile spasms. The mechanism probably is not the same as this, but there are studies in older kids of different seizure types who were steroids, and even IVIG have shown some benefit. Although those are not really widely used, I think what we need here is to get better, I guess a better ability to screen and identify who might have an immunologic cause. So if you know, again, if the screening improves, and this particular antibody may not be the only type to be associated with epilepsy, there might be other types like something called an anti-GAD antibody, which is associated also with diabetes. So there's some kids who develop type 1 diabetes as well as seizures, and they too may have an underlying immunologic cause. Why this is important, though, is that if you throw a traditional anti-seizure medication at what's really an immunologic problem, you're not going to get anywhere. You have to treat the underlying cause again. So I'll stop there. I'm sorry if I went over a bit.
No, it's okay.
And I apologize. I have to, like I said, I have to kind of run out because I'm getting paged already. But I did clear my schedule so I could have the whole morning. But again, you know, my colleague had to go to a funeral last second, so I promised him I'd cover.
Well, thank you so much
Sure.
for joining.